Senator Smith.
Thank you so much. Welcome, everybody. I'm appreciating very much all of you being here. I want to just follow up a little bit on the question about medication abortion. So mifepristone has been lawfully prescribed to patients since 2000. I'll just ask Dr. Verma, how safe is medication abortion and how effective is it?
Thank you for that question. Medication abortion is incredibly safe and effective. In a recent study of 20,000 patients that have undergone medication abortion, the rate of adverse events was 0.38%. So very, very low. Only about 1% of those patients came to the emergency room after the process, and of those people, about 40% didn't need any treatment.
Okay.
So we know that medication abortion is incredibly safe and effective. And I also want to highlight how dangerous misinformation about the practice of medicine is for our patients, for physicians. The American Board of OBGYNs, which is the board that certifies all of us OBGYNs at this table, has asserted that abortion care is safe, is effective, that medication abortion is safe, that abortion reversal is not something that we can, in good faith, offer to our patients because it can cause serious risks of bleeding and hemorrhage, and that abortion care does not cause preterm birth. And so I just want to highlight some of that misinformation that we've heard today because it can be very dangerous and contradicts what the American Board of OBGYNs and American College of OBGYNs asserts.
We've heard a few things also today about abortion reversal drugs, saline abortions. Is there any misinformation that you'd like to clear up there as well?
Yeah, thank you for that question. Saline abortions is not something that is done in the practice of modern medicine. I have been practicing for about a decade, have never seen or heard it. So that is not a practice that is done. For abortion reversal, my colleagues and I actually studied whether this is a treatment that we could offer to our patients, because if it was a safe treatment and a patient wanted it, I'd be happy to offer it. I am happy to support my patients who want to continue a pregnancy, end a pregnancy, whatever is right for them. And we found we had to stop that study early because people were experiencing significant bleeding and were at risk. And so it is not a safe treatment that is available to patients. That is misinformation.
Thank you. And maybe I'll ask Dr. Linton this. There's been, I'd like to ask you about this question about whether telemedicine for medication abortion is also safe and effective.
So thank you for that. I would reiterate what Dr. Verma said. When we are thinking about providing medication abortion via telemedicine, we have screening questions. And if there are any red flags, if someone does not have a regular menstrual cycle, if somebody is concerned about bleeding or cramping, then they are not eligible for a medication abortion via telemedicine. Of course, our utmost priority in every single patient encounter is patient safety.
Thank you. Ms. Lopez, thank you so much for being here. As you all know, Louisiana recently enacted a law that adds mifepristone and mifepristol, which is another drug used to manage abortion, to the state's controlled substances list. This law would criminalize anyone who possesses the drug without a valid prescription, and it puts it on a category that is in the same category as opioids. I'm just wondering, is there any reason, I mean, what would be the, what do you make of that? And do you believe that medication abortion should be put in the same classification as these other dangerous controlled substances?
The easy answer is no, and I think my colleagues have really reiterated how safe and effective medication abortion is. We have 2 decades of widespread use of study of this drug, so we know that it is safe and effective both here and globally. It has also become an incredibly important option for folks to access abortion care. 2/3 of abortions are now via medication abortion, and so any effort to restrict it further is simply an effort to make abortion more difficult to obtain.
And what impact does that have on women, for example, living in rural communities, people who have a really, who struggle already to get access to care, including women who, you know, are marginalized in so many other ways and don't get access to care?
Yeah, the folks who are most impacted by all of these abortion restrictions are folks who are already marginalized by our healthcare system. So folks of color, the or underinsured, young folks, LGBTQ folks, and folks who, as you said, Senator, live in rural communities. And so it makes it harder to get. We know now that 1 in 5 abortion seekers is traveling out of state to get care. So it means they're leaving their home communities at significant financial, logistical, and emotional cost to themselves and their families.
Thank you. Thank you, Chair Murray.